Good evening, everyone. We welcome you all to OrthoTV online original webinar series. Today, I have with us my very good friend, Dr. Avinash Mahale. He has taught me many things during my residency. He has done his FRCS Edinburgh Trauma and Orthopedics from UK. He is a consultant orthopedic trauma and joint replacement surgeon in Hinduja Hospital, Khar, Criticare Hospital. He is also an assistant honorary professor in BDBA Municipal Hospital, Kandivli. He also runs his own clinic by the name of London Ortho Clinic. Today, he is going to talk to us on a very interesting topic called modern management of Achilles tendon ruptures. So, over to Avinash.
Good morning, good evening, everyone, and thanks, Neeraj, for the grand introduction. And it's great to be again associated with you after a long time, though you are a very active part of the BOS committee now. So we speak about little common injuries, but which are not very commonly properly managed. And that was the whole objective of this presentation when Neeraj asked me to present something slightly different. So Achilles tendon ruptures. So starting with, they are the most common extremity tendon ruptures, and it is very common in the third and the fifth decade of life with a significant male preponderance, as we all know. Classic description is a weekend warrior athlete. Now, what does that mean? It means that usually you have a middle-aged man who's got a poor flexibility, inactive lifestyle, and who's not very accustomed with the sporting activities on a daily basis. So such are the people who are more prone for this type of injury when you suddenly get into any badminton or any basketball or activities which require any forceful dorsiflexion or any jumping around. Interestingly, patients may have certain other issues. For example, they may have visited another clinician, have had some steroid shots taken in the retrocalcaneal area or even in the tendon area. You'll be surprised. Many times they have got associated tendon problems. For example, they may have a tendinitis or a tendinopathy which is ongoing and that can predispose to a rupture. So these things we need to be aware of. A quick history can help in just asking whether they had any pre-existing problems. If you are dealing with athletes, then you should be asking history of any insertional tendinitis, or you should look for insertional tendinitis also. And also you should ask them that whether their ankle has been symptomatic for long, because generally due to overuse, they complain of large amount of pain. Some people give a history of injection of local steroids. Some of them may have taken steroids by oral route also, which can be susceptible for trauma. Fluoroquinolone antibiotics are associated with this type of a condition. And you have to be aware of a background of medical conditions like diabetes, gout, rheumatoid, and kidney diseases, which can affect the wound healing also and affect the collagen nature also of the tendon. So these are the potential risk factors for rupture. Now let us revisit the anatomy of a bit. We are all aware about the anatomy. There is no catch-20 situation here, that it is one of the largest propulsors of the foot, the gastrosoleus complex, and it inserts by a very strong tendon, the Achilles tendon, into the tuberosity of the calcaneum. You can see the retrocalcaneal bursa is not very far from where routinely the injections are planned. Sometimes they get insertional tendinitis and the subcutaneous calcaneal bursa also can get inflamed. So this gastropropulsive complex is a very strong one because it can deliver up to 8 to 10 times force that is required to pull our entire body weight. And that is the reason why eccentric loading or abnormal loading can rupture this tendon. So you will be surprised, but the amount of work that is done by the muscle when we squat is around 220 Newton. And the work that is done when we are actually hopping around is around 3,800 Newton. So, which is quite large compared to the overall work which is done by the other group of muscles. And that is the reason this particular muscular tendinous complex is more common for ruptures. But surprisingly, the rupture does not occur in different places. Most commonly, if it is related to the degeneration, the rupture does occur in an area which is the watershed area. Now, the whole anatomy is such that the Achilles tendon is supplied by the posterior tibial artery, and this watershed area is presumably around 2 to 6 centimeters from the insertion, which is proximal to the calcaneal tuberosity, where it is properly inserted. Now, physiologically, this tendon has got a remarkable response to stress, and exercise can induce increase in the tendon diameter. So exercise is actually good. Disuse can lead to atrophy of the collagen fibers. Age-related changes in the collagen, in the water content, in the proteoglycans can happen. But the collagen content is more important. And also the density of the cells and the tenocytes are important because this also undergoes changes. So we have nowadays people who want to be very physically active, especially in the elderly age group. They want to keep their weight under control and they get into various type of sporting activities. So as long as they condition themselves properly and as long as they are aware that there are certain moments when they have a risk for injury, they should be educated on this in case they happen to see you in the early stages like tendinitis or any tendinopathy involving the tendon. They should be made aware of ruptures. And also they should be discouraged from having steroid injections or any, sort of injections around the Achilles tendon. Older athletes are more susceptible to injury and hence education is very important when they are getting into these programs. Now, coming to the younger athletes and younger individuals, usually it is an indirect trauma. It is like eccentric forces to a dorsiflex foot or a sudden dorsiflexion of the foot can result in this. Also, we may have seen a lot of direct trauma patients. Sometimes we also get acute open injuries of the Achilles tendon, which are as a result of the direct trauma and require immediate surgical intervention. What is a clinical presentation? This is winding up in a nutshell. We started from our medical college days to our residency days, so nothing very exciting in this. But the main thing what we need to see as clinicians is a classical history of a pop given by the patient, weakness of the push-off phase if they come to you after a few days and they are not happy about toddling along and they have a limp. There will be a visible palpable defect. Many times if they are bulky and if the tendon is not completely ruptured, we may not see the defect. We all know what is Simmons test, where we ask the patient to relax the knee on the basically the chair and visualize the calf and the tendon properly and squeeze the calf and see whether there is any passive plantar flexion of the foot. O'Brien's needle test was described, but we rarely do this. Nowadays, we directly move on to the investigations if we are not convinced of any clinical signs of rupture or if we have a doubt about clinical rupture. So, what is the pathological process? Pathological process is actually poorly understood. The rupture occurs in the watershed area where presumably there is a decreased perfusion during stretching maneuvers. Hence, in the other times, this rupture does not take place. There has to be some sort of eccentric loading of the tendon. There are theories linked to problems in the cross-linking of the collagen fibers and some degenerative changes will occur with age, which we have already discussed. And overall, summarizing in the nutshell, chronic tendon degeneration, acute mechanical overload, and usually both are the complementary factors which can initiate a rupture. Diagnosis is pretty straightforward. Clinically also, I have a tendency to do the USG. I have a lot of patients who have come to me who have already had an MRI done by their primary clinician or primary orthopedic surgeon. Now, basically, USG is inexpensive. It is a very fast and a dynamic imaging. And the advantage of the USG is that it can also measure the gap closure, which we'll talk about later. MRI can get more expensive. Sometimes patients are claustrophobic. It can help you if you want to monitor the healing process, and it can also help to know whether any tendinopathy or any pre-existing changes are there. So in certain chronic disorders, MRI is pretty useful. But up to you, it is your choice depending upon how you manage it. I have a tendency to go for ultrasound first. I rarely do an MRI. Now, why are we discussing all this? See, there are a lot of red flags and controversies in managing this type of an injury. Now, what are these? The controversy exists regarding operative versus non-operative treatment. Many advocate non-operative treatment because you get a similar strength of motion, functional level of activities, and as a result of both. Surgical repair in athletic patients have proven in the literature that the re-rupture rates are quite low. And surgical treatment versus non-operative treatment, the re-rupture rates are pretty high in the non-operative, around 10 to 30% even in some papers. Carden et al. In 1987 reported non-operative results for comparative operative when the ruptures were first casted in first 48 hours. But after 1987, a lot of changes have happened, a lot of papers have come up, which we'll talk about later. And studies do indicate that operative techniques also have complications, which we'll talk about later. So talking about casting, I don't know how many of you watching me enter into this process of casting the tendo Achilles after a rupture. Basically, if the patient is refusing surgery or if you're having some surgical contraindications, you might land up doing this, but which I don't routinely do. Now, obviously, when you are casting, the complications of surgery are obviated. Re-rupture rates can go up to 15%, and some literature papers have reported up to 40 to 50% as well. It is a very cumbersome treatment because the patient enters into a below knee cast for at least 8 weeks. Conflicting reports if the cast should be below knee or above knee. I used to see in my old residency days in JJ Hospital, where we used to cast above knee for 4 weeks, followed by below knee for another 4 weeks, and then probably plantigrade and make them walk another 4 weeks. So it becomes a very cumbersome treatment. And there are conflicting reports regarding the exact timing of weight bearing. Now, if you've got an elderly patient with poor comorbidities, rheumatoid arthritis, a lot of problems in mobility, obese, you're not going to get very comfortable giving him a cast and then getting away with the entire treatment for 3 months. Tendon elongation, weaker plantar flexion are other issues. So non-operative treatment is not without complications. It is only thing is these complications are more digested because you're not having any diastrates sort of situation. So what is the role of surgery? To me, professional athletes returning back to their pre-injury level of training and fitness and lower incidence of re-rupture rates are the three most important factors which I take into consideration. And the re-rupture rates are quite low after the repairs, around 2 to 3% in the literature. So let us first speak about surgery, and then we will go into the main topic of discussion of today's presentation, that is the functional bracing, which I am doing routinely along with our Birmingham sports injury unit. So what are the goals of surgery? Goals of surgery are you preserve the paratenon blood supply, and hence you be very delicate with the soft tissue dissection. I usually take a posteromedial incision because a lateral incision can damage the sural nerve and you may land up with a bigger complication of sural nerve neuritis. If anybody has seen it, you may come to know how much nagging it is for the surgeon because the patient keeps coming back again and again. So basically you need to go and keep the patient prone. A midline incision generally is avoided because scarring can happen and then it can irritate the footwear also. So take care of the sural nerve, debride the ends, and we all are quite familiar from our residency days how we repair this either by a modified Kessler or a Bunnell type of stitch with 2 to 4 stranded sutures, which are usually of ethylene. Excuse me. Close paratenon separately because that is one which can play a factor in your healing and also providing a blood supply. Now, surgery of a open repair versus a percutaneous surgery. Nowadays, the concept about percutaneous surgery has come up in a big way, and there are a lot of surgeons who have started doing that. It entirely depends upon your comfort level. My background of training, I am more comfortable doing an open repair, but percutaneous techniques we have done time and again. There have been papers which have been published, and this was a comparative study in the Journal of Foot and Ankle Surgery by Andrew and Anderson et al., where they studied around 270 patients which were consecutive for Achilles tendon ruptures, which were managed with basically open techniques as well as they were managed with fiber wire suturing by percutaneous technique. And both these groups, there were majority of the patients who were involved were basketball players, and they came to the conclusion that this is one of the largest single center studies of Achilles tendon ruptures, where they studied up to 169 patients who were done by open technique and 101 patients who were done by the percutaneous repair, and they have reported lower complication rates for operatively treated Achilles tendon ruptures compared to the previous reports. The overall complication rate for operatively treated ruptures were 8.5% with no re-ruptures, and most of the patients, 88% of them, were able to return to their baseline activity level within 5 months after the surgery. And there were no differences in the post-operative complication rates as such between the percutaneous method versus the open technique which was followed. So this is an interesting observation because when I was in my training in England in the earlier days as a registrar, we were taught that percutaneous Achilles tendon, there is a higher complication rate of sural nerve damage. Now this is known to happen. However, it is known to happen if your numbers are less and if you're in the initial years of training. So as long as you know the sural nerve anatomy, you are less likely to damage the tendon, and the results are pretty equivocal as far as the two techniques are concerned. So summarizing, the advantages of surgical procedure in this particular situation is re-rupture rates are quite low, rehab is rapid, early return to work which should be looked into also, and quicker return to sports in athletic individuals. So these are the potential advantages of surgery which cannot be really undermined whenever we get this type of a problem. Now, why are we discussing all this? We are discussing because the complication rate following Achilles tendon repair is quite high. The literature has reported up to 30%, 15 to 30% skin complication, and this can be very nagging for the surgeon because this becomes an ongoing issue due to the lack or due to the poor blood supply. Deep infection can be devastating because you may lose the substance of the Achilles tendon, you may land up with repeated debridements, and this will also affect the rehab because the ankle tends to get stiffer over a period of time. Keloid formation is seen in certain group individual. Thickening of the tendon in the repaired area is common and they sometimes have a lot of discomfort. Re-rupture rates are low, so which is a possibility again after repairs depending upon how you are rehabilitating them, and you have to go really very slow in the initial phase of treatment. Now, if you see the literature, the overall complication rate is around 10%, which is reasonably high. And the deep infection, superficial infections happen, fistula formation can happen, skin necrosis. I'm sure we all have seen this, and usually we see patients who have been operated by somebody else as our patients might be landing up with someone else. This, which did not happen in the NHS very frequently, but it does happen in our Indian situation quite often. Sutures can get complicated by granuloma formation, and this try to come out in some or the other way. And sural nerve damage can give rise to a neuritic type of pain, which is quite disabling for the patient, and they forget about the original injury. So there are complications associated, and we will be discussing as to how we can avoid this by selecting the right group of patients. So this is very common. This was one of my patients who was operated somewhere else, and even the tendon had become necrotic. So initially we had to just do a debridement with a VAC closure. There are a lot of papers published. In fact, there was Nicola Maffuli's paper along with Amol Saxena, where they have seen wound complication pertaining to 219 surgeries. And they have clearly described that sometimes wound complications may be unavoidable. Suture granulomas usually appear very delayed. Absorbable and non-absorbable sutures can equally cause the problem. Many of the patients had infection, wound infection, 3 had a keloid formation, and 6 had suture abscesses. So the total complication rate in this series also went up to 10%. So all these things have to be discussed with the patient. And the poor risk factor patients also have to be identified, because if you got a rheumatoid patient, a diabetic patient, a smoker patient, and if you're jumping and operating him, then this is not good news for you. Hence, you have to really choose the patient whom you're operating. Overall, this study also showed that such type of patients are really high risk to land up with more complications. So dangers of open surgery, we have also discussed, but now how can we prevent them? So then the papers started coming up in the World Journal of Orthopaedics about systematic review of management of these injuries, where they divided into conservative treatments, operative treatment, and also one with the functional orthosis. So the base of my talk today is about this functional rehabilitation or the functional bracing for Achilles tendon injury. There was a big trial which was conducted in the BMJ where they did a study of functional bracing in rehabilitation protocol. And this was the UK STAR study, which was a multi-center randomized controlled trial for this type of rupture tendons. And they came to very satisfactory results after the study was completed. So what is the basic hypothesis for functional bracing for Achilles tendon injuries? So the basic hypothesis is that the tendons heal under slight load. Micromotion at the opposed tendon can result in better quality tenocytes and collagen formation. So I repeat, it is a micromotion and not rigid immobilization that is helpful for the tendon healing. So how does this functional brace look? There are various available in the market. In the United Kingdom, we are using a slightly different one. This is manufactured in Germany, but it is easily available in India. I'm not advocating any particular brand, but I am using this one routinely. That is why I'm sharing the pictures with you. Now, what is the advantage of this type of a functional boot? The advantage is, I don't know if you can see my cursor, but there are methods where you can change the plantar flexion angle. Now, if I show you the backside of this boot, these are the adjustments that can be done to change the angle of the plantar flexion as the treatment progresses on. So this you can see, I have kept it in quite a bit of equinus. You can see from the side. Now, we will come back to this brace again. We have to understand now what is the biology of the tendon healing. So biology of the tendon healing is that there are tenocytes. These tenocytes will heal by intrinsic healing as well as extrinsic healing. In intrinsic healing, what happens when you have repaired it, the tenocytes will bridge. It is like primary bone healing. So it will occur basically without any direct blood supply to the tendon. It will intrinsically happen due to the proliferation of the tenocytes. Eccentric healing happens when there is a fibroblastic proliferation from the epitenon, and in this type of a healing, there is more tendency for adhesions with immobility. For example, when we have casted the patient, they will generally, because of immobility, the scar tissue and the collagen which will be formed, which will be of much substandard quality, and that can give rise to higher incidence of re-ruptures. So understanding the biology of the tendon healing is very important. Otherwise, we are not going to move forward. So what I mean to say, in a functional bracing, you are giving a scope for the patient to move the ankle, move the tendon, and that can have a big impact on the healing process. Now, the boot, what does the boot essentially do? It allows further plantar flexion, but it has got a dorsiflexion stop. So for example, if I have kept the patient in a 20-degree plantar flexion or equinus, it will allow me further plantar flexion to go on as the patient can move the ankle. However, the dorsiflexion stop will prevent him from inadvertently damaging a healing tendon. This was our unit in BURTON-on-TRENT, which is very close to Birmingham city center, around 30 miles from there. I worked in this unit for long. On the left side, you can see Mr. Mark Hamlet. On the right side, you see Mr. Bosley, who's currently one of my colleagues in Sheffield area, who's become a consultant for foot and ankle. And Mark Hamlet was a sports injury specialist. Coincidentally, was also a very good shoulder surgeon and did a lot of reverse polarity replacements that time, probably around 40 to 50 a year. But Achilles tendon was a special area for his interest. That is why I got involved in this type of studies. And what was a procedure that we routinely followed when a patient came? We used to get an ultrasound scan first to confirm the rupture. And then we used to ask the radiologist to see whether the gap is closing. And this gap closure can be assessed on plantar flexion of the ankle. Hence, ultrasound is a better investigation because it is a dynamic scan and there is no role for just getting static images. After the ultrasound scan is complete and we are convinced that the gap closure is less than around 15 millimeters, then it becomes amenable for a functional bracing. And we used to give a special type of a boot over there, but here I am giving the hinged VACOPED boot, which is set to the maximum plantar flexion angle in order to close the gap. The boot is kept in full equinus for 4 weeks at 30 degrees and in a static mode completely for the first 4 weeks. Static mode means I don't even allow the plantar flexion of the ankle in the first 4 weeks. Some people disagree on this. They also allow a dynamic mode, but I prefer a static mode because that was a protocol followed in our unit. In the next level, after 4 weeks, when the patient comes to you, you can bring the equinus down by 15 degrees and you can get it into a dynamic mode. Now, dynamic mode means that he can further plantar flex the foot. Now, this is the whole ballgame of this treatment, that you are allowing movement to happen, you are allowing some sort of an intrinsic healing to happen, you are allowing biological healing to happen. And this, in a way, and even if it is extrinsic healing, the healing is bound to produce a better scar tissue. And this is exactly what is advocated. A little bit of a movement, if it can happen, so the advantage is that the ankle doesn't become stiff and the quality of the tendon which you will get at the end is a lot better compared to you have casted for 12 weeks. Increasing the dorsiflexion till 12 weeks, till the foot becomes completely plantigrade, and the boot has got a dorsiflexion stop but allows further plantar flexion to permit the micromotion, which we have already discussed. So these are the angles in which you can really set it. And the main advantage is that the patient is able to walk on this from day one. I had a lady who was a CEO of a very big company in Singapore who sustained acute rupture. She was newly appointed, so she would have lost the job after she would have got operated because she would have got out of action. So we fitted her a brace on day one and she was to work, and she's still thanking me because she's got full function and went back to even her badminton at the original level. So advantage is definitely early mobilization, and you can make the patient walk immediately, even though in the equinus, then the patient can easily walk along with the help of crutches or a walker frame, depending upon the initial level of mobility. The range of motion in this particular patient, you can see at the end of 3 months, you can compare it with the opposite ankle. There is hardly any change. The right side ankle was put in a brace, and dorsiflexion also is quite comparable and without any functional really disability. When the patient is off the brace, you can hardly come to know what has really happened. So there are a lot of papers where they have identified risk factors And you have to identify these risk factors before you decide to operate on these patients. I'm not discouraging you from operating. I'm basically, the whole purpose of this talk is to identify which patients will do better after surgery and which patients are likely to cause you problems, and can they get away with your non-operative treatment in a functional bracing. So tobacco, diabetes, and age, gender in the elderly we have already spoken about. Body mass index, obese patients are more susceptible, and patients on steroids. So what are the advantages of the functional boot which we have discussed? It gives excellent healing, which is more biological. There is no stiffness of the ankle. It gives a less bulky tendon, hence the patients don't become potential complainants. Less chances of re-rupture. In fact, there are recent papers which have shown that the re-rupture rates are almost comparable to operative repair. Early weight bearing can be initiated, promotion of intrinsic healing, and avoidance of cumbersome effects of cast, and of course the complications of surgery. So you see the advantages are enormous. Yes, there is a cost factor involved. These functional braces are quite expensive because they are imported from abroad. But if the patient can be got into the confidence, and if you overall calculate the cost of treatment, it certainly comes to less than the operative cost. Depends upon where and which areas you practice. So there have been studies done. There are meta-analyses which have been done in the JBJS, and they have clearly demonstrated that conservative treatment should be considered at centers which are using functional rehabilitation and not only with casting. And similar rates to surgical treatment have been seen, and repair should be performed, but early active motion with the help of some sort of a cast brace should be initiated. Otherwise, your surgical repair also may not give rise to satisfactory results. So this is a small video clip. This patient came to me after 12 weeks, and you can see him walking. He became so much used to the brace that after discontinuing the brace, he continued it for the further 4 weeks. And then finally, we got rid of it at 16 weeks. Sorry about that. So what is the decision making? See, neither patient nor the surgeon wants a second surgery, and mainly in an Achilles tendon, it may be a wound complication or a re-rupture. So you have to be very, very careful in selecting your patient. So the take-home message from my talk today is that you need to identify your patient. This is not a resident level operation when you're operating in Bridge Candy or in Hinduja Hospital, but even in a municipal setup or in a government setup, your residents have to get the correct level of training. And we have to be training ourselves with modern times. So surgery, no surgery is entirely your decision depending upon your patient. But remember one thing, you have to have a dialogue with the patient. Because if you don't have a dialogue, then he becomes a potential complainant after the complications happen, and when the rehabilitation can get prolonged as a result of complications. And along with that, your conscience is clear that you have offered him the options of other forms of treatment which give equally sort of rewarding results. So in my hands, I definitely do operative intervention in athletes who want a quicker return to sports and who don't have any local skin issues. But I've got a big role for functional bracing, especially in the high risk groups which I have mentioned, and it is a very good option compared to only conservative methods like Biloni casting. Thank you very much. I thank the BOS and Dr. Neeraj Bijlani for giving me this opportunity, and the audience for giving me a hearing for at least a long period of time. Thank you so much.
Yeah, thank you. Thank you, Avinash. So I'll just stop your screen share, and we'll have a few questions. So question number one is that there are many people who have tendon ruptures after a Haglund's deformity or a big calcaneal spur.
Yes.
And they are mainly elderly or middle age group. Will you be using the brace in those also, or will you be going for surgery?
Yes. Now, I have been in this situation before where patients have been advised surgery and they have come to me for a second opinion also. In fact, I had one elderly patient who had a Haglund spur who had a double rupture. He had a rupture 2 centimeters from the insertion and 5 centimeters from the insertion. And this was a learning point for me also. We put him in a VACOPED brace, and you will be amazed. This guy keeps calling me every second or third month just to thank me, because obviously the cost was avoided, but he landed up with no complications. So I think in the end, what I feel is that the requirement of an elderly person or the functional demands are quite less, and that's the reason this type of a treatment can really be tried. And there is absolutely no side effect of the treatment. If you go to see, it is like a foolproof agenda in your hands. So I would still advocate it.
What about situations where there is a gap, where the patient has come to you delayed?
Yes. Even though our Birmingham unit was very strict on the acute tendon ruptures, like 15 millimeter was the minimum which we were expecting. And beyond that, if it was anything more than that, then we were erring on the side of surgery if the gap was not closing properly. But then you have to choose your patient. Now, for example, if you got a patient who's got rheumatoid arthritis, a poor skin, who's a diabetic, who's a smoker, then I wouldn't, even if your gap is say around, instead of 15 millimeter, if it is 20, 25 millimeter, still I would give him a VACOPED brace because I know that my surgery is not going to be foolproof here. On the other hand, if you got a young patient who's got a good skin condition, no comorbidities, and the gap closure is not adequate, there probably I would err on the side of operative treatment because I don't want a re-rupture. So you have to really weigh every patient according to the merit. And that is the whole crux of this talk, that, you know, not all Achilles tendon injuries, like I did in my residency days, this was a resident level operation, you know, but then later on I realized that it is not that easy, the decision making as well as the outcome. Okay, that's why we are entering into all this, the functional bracing area. But it is a very dynamic tool and it is a very effective tool, which if you can really explain to your patient properly, they can do well.
Okay. And about the bracing, so you start say with 20 degrees or equinus and avoid the dorsiflexion completely. So how do you go about, how frequently do you call the patient? How do you go about doing the treatment further?
Yes. Now, there are two people who are involved in this. One is the company guy who supplies the brace, because if you keep on changing the company guy, they don't know how to exactly adjust the angles. And second thing, what I do as a precautionary measure, I call them to the clinic, both of them together. So the company guy along with the patient comes to the clinic and the initial follow-up is organized. You don't have to really see them very frequently, but you have to explain to the patient that it will involve at least 4 to 5 consultations. So in the first consultation, you diagnose a problem. In the second consultation, if possible, because you have to arrange for the brace, you put the brace in 30-degree equinus and make sure that they are comfortable walking around in front of your eyes along with the rep around. And any problems related to the brace, the rep can easily explain to them. And you will be surprised that these people give very good service at home also. So in case they have any problems at home, the reps are happy to go home and sort it out. And then I call them every month. Basically, after 4 weeks, I get them to 15-degree plantar flexion level, and then I call them to make it 0-degree, and then finally I'll call them at the end of 12 weeks, and then probably at the end of 16 weeks to just make sure that they are pretty okay in the boot. So 12 to 16 weeks is the time when I am actually using the boot, and then I discard it.
Okay. Do you do a repeat sonography to see if it is healing?
That is a very good question. I had talked with one of our radiologists regarding this. Now, the problem with sonography is that sonography will show you the continuity of the tendon, and it may not exactly give you the quality of the tendon. So, for assessing the exact nature and the healing process, I think an MRI scan is much more fruitful than a sonography. Sonography will help you to establish structural integrity, which we have done in the past and we have seen. But I was talking to Dr. Roshan Shetty, one of the eminent radiologists in our part of the town, and we came to the conclusion that we will probably start doing MRI scans for reviewing our patients. Now, I've got already a series of around 7 to 8 patients which I've treated in the last 2 years, and we'll be soon doing revaluation MRI scans because all of them are at 2 years of follow-up, and then we'll update you as to what were the MRI findings. But one thing is there, clinically they are ecstatic and they are doing extremely well. We are very happy with the outcome.
About the surgery also. So what I have seen is that, I don't know now, maybe the MRI reporting has improved. In one of my first cases where with the first time where I did a FHL transfer, I was very surprised that when I asked the radiologist clearly on the phone, he said the gap is not much. It's almost in continuity. It's only partial tear. But when I opened, it was only the paratendon which was continuous and the tendon was fully retracted and it was not coming in place. So I had to actually wash out, learn about FHL transfer and then come back and do the FHL transfer. Yes. Which was a tedious task. That patient was my Pandit. So basically, he did it. He did a very good job. Eventually came for multiple surgeries. He became all right. But this is what it is. So how frequently do you think that this thing can be misguided in the MRI, or can we read it now with the latest radiologist?
See, I am very picky about doing the ultrasound done, but with whom? Because I have seen that if the person is inexperienced in musculoskeletal ultrasound, the possibility of you getting a misinformation is quite high. Hence, there are a handful of radiologists you will be trusting to do the job for you, because ultrasound is a dynamic investigation. It is very operator dependent. Hence, I have 2-3 radiologists who do the job for me, whom I can trust. If the report is from some other radiologist, then usually it is not a complete one, where they don't tell me the information about exact gap, how much is a gap closure on plantar flexion. So these are the things you might want to ask the radiologist. I don't think it is that tricky investigation. It is operator dependent, no doubt, but people are not routinely doing it, and that is why probably there is a less experience in this. MRI will exactly give you how much is the gap, but the MRI is not dynamic. Only in one of the units in Birmingham, we had a dynamic MRI done also for our patellofemoral trackings and Achilles tendon, but I have not seen dynamic MRI elsewhere. Ultrasound would be still my investigation of choice. You had a catch-20 situation. I hope it doesn't frequently arise because that
nowadays we are prepared with FHL transfer whenever it happens. So the last question is about the surgical intervention. So if you are going to do a surgery and if it is not repairable, what will be your first choice? Will it be FHL transfer or will it be some other surgery?
Yeah, so there are options available. You've got a peroneus muscle available, the peroneus brevis. You've got a FHL available. I generally tend to err on the taking the peroneus brevis, and I've also been part of doing repairs where we have taken like a Viva advancement flaps from the aponeurosis of the Achilles tendon also. So depending upon the amount of gap that is present, we should plan it. Yes, FHL is definitely an option. We have done that in the past, and it does give good results to augment the repair. And remember one thing, the problem is that once you augment it, the tendon becomes more bulky. So hence, whatever you are using, make it sure that you are not using excessive amount of augmentation in order to sort of get a inferior outcome. But strengthening wise or reinforcing wise, I don't think it is a problem. You can use whatever you are comfortable with, and it can give a reasonably good outcome.
And what about surgeries for basic without ruptures, like insertional tendinopathy, where we basically have to remove the tendon, remove the Eagle's deformity, and then put it back? What is your experience about that?
My experience currently last few years is I've been treating the complications who have been operated somewhere else, because I've got a very high threshold to operate on insertional Achilles tendinopathy. The reason being that because the blood supply is impaired, there is an inferior outcome once you plan to do open surgery. So there is a role if you feel that the patient has digested all the possible non-operative measures, including possibility of a PRP injection, including nowadays they are using radio frequency. Some of my arthroscopy colleagues are using even radio frequency to ablate that area and get the necessary outcome. If you have burnt all the bridges, then I would go for surgery. I must say that the background of my training in England, we saw very, very few procedures for this particular problem being done because the complication rates were high. Hence, for a new surgeon or for surgeons in training who have just recently started the practice, my sincere advice will be exhaust all non-operative methods before you jump into surgeries in this area.
Okay. Okay. Thank you, Dr. Avinash.
Also has a big role. Sorry.
Yeah. Okay. Thank you, Dr. Avinash. We thank you for sparing your time tonight. And we thank all our viewers on OrthoTV who have been seeing us week after week. This is the longest running series, the OrthoTV original webinar series. So thank you, everyone, and good night.
Thanks, everyone. Thanks, Neeraj, for the opportunity.